Hello, everyone. Thanks for joining us again this week. We have another pretty exciting talk, I think, with Dr. Hobson and Dr. Webb. We're really going to be focused today on what it's like joining your new role, kind of as a leader of the team and as a surgeon that's no longer working under an attending surgeon in training. You can see the titles of our little talks there. I think they weave together pretty well. We're going to do the standard format that we've typically done, which is 20 minutes for each talk, with just a brief introduction in between, and then 20 minutes at the end where we will answer questions. So during this talk, if you please can put your questions in the chat box, I'm happy to ask those for you at the end. Or if you would like to ask them, you just hit the raise hand button, and when we get to the question portion, we'll bring you over to the panel and you can ask the question yourself, which would be just fine. So without further ado, we'll start with Dr. Webb. He's going to give us his side of things. His talk is titled, "You're the Captain Now, Before the Cut." So it's all the things as a surgeon that we want to make sure we don't forget to do now that we're the boss. So Dr. Webb.
All right, so let me share my screen here. Good evening, everyone. Thank you, John, for the introduction. For those who are unaware, I'm an orthopedic spine surgeon here in San Antonio, Texas. In a fairly large spine practice, there are 10 spine surgeons, and we have about 5 or 6 pain management physicians with a couple guys who do general orthopedics. But this is a quote that I would start off with. If you fail to plan, you're planning to fail. But I wanted to start off with a quick case. This is a 67-year-old female. She presented to my office about 2 months ago with mostly neck pain. She has a history of psoriasis, otherwise no medical comorbidities. She's been having this neck pain for about 2 months. She's had several falls. With the most recent one, she fell on her chin, went to the ER, they got some scans, and they sent her to my office. Most notable on physical exam, she did have a positive Hoffman on the right side. Otherwise, she was neuro stable. She had full strength for the most part. She did have some maybe 4+ out of 5 in her left triceps, but otherwise no other kind of concerning physical exam findings. These are her x-rays here. This is AP and lateral of the cervical spine. You can see there's something that looks abnormal, kind of at the body of 4, 5, and then possibly some of 6. She came in, I got some flexion extension views, which was indicated this was a stable. There's nothing that was slipping. But she did come in with these images here that showed her cervical spine. There was some destructive lesion or interosseous lesion inside of her vertebral bodies here that was causing some destruction. The CT scan, I'll just scroll through this real quick, and you can see she has a large, looks like possibly a lytic lesion in the body, mostly of C4 with some destruction and fracture of C5, and then that kind of extends down to C6. She did come in with a MRI scan also, which showed some stenosis with some myelomalacia behind the body of C3, C4. She was pretty stenotic at these levels also, and I'll just scroll through these images here. The presumptive diagnosis from the radiologist was multiple myeloma. But I wanted to highlight that throughout this talk, this is something that you should always have in the back of your head, but you should always kind of question what the radiologist, what their report reads, and not just go off of what it says. Just take it, a really good history and make sure that things kind of add up. But the differential for someone who's over the age of 50 is metastatic. You're looking at Mets, myeloma, lymphoma, whether this is like a less likely to MFH of bone, whether this is some type of infection or burnt out infection or some type of vascular lesion. But these are just the ABCs of what I came up with. As I'm, my first year out in practice, these are the things that I'm thinking about when I'm booking a case or actually planning for a case. I was just on call this past week. I do take some general orthopedic trauma call. This is a 25-year-old female who fell from an electric scooter, who presented to the ER. No significant past medical history, but she was a smoker. orthopedics was consulted for this calcaneal tongue type fracture here, and she did have some tinting of the skin. And I saw this and I was like, crap, I haven't done one of these in like maybe 2 years or so. So you can see the tinting of the skin there. So one of my chiefs when I was an intern, one of the biggest pieces of advice that she gave me was to take notes after every single case. And this is something that I would highly recommend. You're a resident medical student. I kept it on a Word document. After every single case, I took a couple of minutes just to ask myself, what could I take away from this case? Any notes in terms of positioning, what approach, the incision, what implants were used. And I had these notes from my orthopedic trauma rotation. This is one of our trauma surgeons who, the last case that we did approximately 2 years ago. And this is exactly how I kind of prepared for this case. I put the patient in a prone position and percutaneously reduced the fracture with a Webber clamp, and then put some cannulated screws across her, this calcaneus here. So this kind of highlights the importance of just taking really good notes, and just be very mindful of what your attendings are doing, or even your senior surgeons or fellows are doing, so that when you're out in practice, you can refer back to these notes over time. I think it's important to review early, whether that's dissection videos, anatomy books, old surgical notes. And throughout my whole training, residency, and fellowship, I had probably like a 200-page document that had just pictures of things when I was in the lab, or pictures from the anatomy book. Whenever I'm doing a ACDF, I just did one on Monday. I review these notes, I review my anatomy, and I think that's very important. Always just remember to book extra time. When you're starting off in practice, you're still trying to learn the ropes, you're still trying to get to know the OR staff, and I think what you don't want to do is book a case for an hour and it takes you 4 or 5 hours. So always just book it a little bit extra time. It will make you look like a superstar if you told everyone it will take 4 hours, but you actually get done in 2 hours. It's important to write out every single step. If you're planning for a ALIF or some type of corpectomy, just write out the steps. That way you can go through those things in your head, and just make a list of everything that you need throughout that case. I'm pretty sure the nurses they hate when you're constantly calling out things. I need this, I need that, and they're constantly have to get up from their chair, put down their Facebook or Instagram, and then get all these things for you. So what I do is make a little list, and I'll hand that list to the circulator as soon as I get into the room. I want number 1 Vicryl, 2O Vicryls, 3O monocryl, Dermabond, bank powder, and I'll have a whole list, and I go through those steps in my head and come up with this list, and I'll give it to the circulator. So that communication process. Be very thorough, make check marks, and just mark things off. There's a lot of moving parts when you're out in practice. I probably have 6 or 7 cases that are pending now, and it's kind of hard to remember every single detail about every single patient. I recently had a patient that I had booked for a 2-level ACDF, and he had a lot of stenosis, was not myelopathic, but I was reviewing his labs the night before surgery and saw that his A1C was 9.9%. So that was a learning point for me, is just to make sure that I'm very thorough reviewing their labs, even a week or 2 before surgery, just to avoid cancellations and patients getting upset. So go through their labs, make notes, make check marks. And because of this, I started just an Excel document that I keep all of my patients, and I check it off once I review their labs, once I look at their chest x-ray and their EKG. This is something that is an evolving process, something I've learned over the last few months. I think it's important to call your mentors, singers, get their opinions. I actually called Izzy about this case here that I'm presenting tonight. They've been through this. I'm pretty sure they've seen something similar or can point you in the right direction. Review your cases with them. I put most of my big cases on PowerPoints. That way it's easier to communicate. I can just text the PowerPoint to one of my mentors and see what their thoughts are, and just compare your, compare your plans. Take this is probably the biggest thing that I learned, took away from my training, is take detailed notes in your training in terms of positioning, incision type, approach, trays. What are their post-op protocols? When do they let patients, ambulate, weight bearers tolerate it? This is just three of the surgeons that I worked with in terms of orthopedic total knee replacements. And these are some of their particulars. Dr. Mori liked aspirin, 325 BID post-op for 4 weeks. Dr. Stryker did some TXA, 1 gram before, 1 gram after. And when I'm doing cases, I always look back at what the other surgeons were doing throughout my training, just to kind of compare my kind of plan from what they were doing, because it's very easy to forget those things, especially in fellowship when there's 20 plus spine surgeons that you're working with. And then execute. You want to arrive early. It's nothing like trying to show up to a case and you are running late. I did this past week as an OR team huddle. Got the circulator together, the neuromonitoring tech, the OR tech, and we just made a plan. Say, hey, this is what we're going to do. This is what I need, just to avoid any confusion, and communication is extremely important. Get everyone involved. The x-ray techs who are taking your x-rays, I will commonly just say, hey, what level is this needle when I'm doing my ACDF, making sure we're at the right disc space? What level is this? Just to make sure that I'm at the correct level, and just making sure that everyone is involved and making sure that they feel like they're a part of the team as well. And always remember to remain calm. You hear all these stories about surgeons who are very, they yell or they do things in the OR, and some surgeons may throw things across the OR. You just don't want to be that surgeon. So if you have a dural tear, just remain calm. Just ask for a suture. And remember that you have to complete the rest of the case. And that's kind of what I took away from Dr. Derman's talk in fellowship. Just remain calm, put a patty over it, take a deep breath, step away for a second, and then, get back into it. Going back to the patient who presented with this neck pain and these lesions in her neck, her labs were normal. I admitted her to the hospital for my clinic for a full metastatic workup. I just wasn't really sure about the diagnosis that the radiologist kind of made with multiple myeloma. Her ESR, CRP were normal. She had a normal TSH, ALK phos, and her SPEP, UPEP were negative. So the differential, as we talked about, was this, but just always kind of confirm what you're thinking, what your history, your physical exam, and your imaging studies. And her diagnosis, for some reason, my plan was to do a corpectomy. I believe this was C4 corpectomy, and to do go through the front to stabilize her spine, decompress her. But for some reason, something told me to get a CT angio, just because I wanted to see where her vertebral arteries were, just to see, because the CT scan, it looks like there was some involvement of the vertebral arteries when I was looking through her scans. So I got a CT scan, and every other read before this said multiple myeloma, but the CT angio showed a large type 3 AVM. The feeders were the V2 segments of the vert and the thyrocervical artery. So this was a really big learning point for me to not really trust what the radiologists, what they report, because if I would have taken this patient for that corpectomy and going in the front of her neck, I'm pretty sure she would have bled out on the table. So, and in practice, that would have destroyed my confidence. And you just don't want to be that new surgeon in town who has a big complication like this. So just always review your imaging studies very thoroughly. Call the radiologist. I actually went to the radiologist to talk to him about the scans. I'm like, hey, this doesn't look like what the reports kind of mention, and I'm glad I got the CT angio. This is just a picture. You can see those large tortuous vessels kind of entering into the body, and that would have been a big problem going anteriorly. So I talked to her kind of about just watching this versus she did have some myelomalacia. She was, had a diagnosis with myelopathy. So I ended up taking her for a C2 to T1 just to stabilize that posterior aspect of her spine. And then part of your pre-op planning is always just making sure that you know what size screws that you want, the trajectory, and making sure that you're going to stay off the verge. Her C2 pedicles were very small. I didn't think I can get a screw in there, so actually we put some par screws at C2. And you can see that the vert on the left side is encroaching on the pedicle there. And then going down to C3, got some lateral mass screws there. I didn't feel like I can get one on the right side at C4. And then this level here is so collapsed that it was pretty impossible to get a screw inside there. And then the next level down, C6. And then C7, pretty decent size pedicles, and a T1 as well. This is another pictures of her scan of her MRI here. And this is what we did. C2 to T1, did a laminectomy from C3 to C7 to decompress that area. She did have good collateral circulation in her vert. So I actually got the endovascular neurosurgeon to embolize, and he sacrificed her right vertebral artery before the case. So the plan for her, possibly some radiation, possibly re-embolize. That's what we did before surgery. I had the endovascular neurosurgery surgeon embolize her, and hopefully that I can, I talked to pretty much 4 or 5 of my mentors. No one has seen this before, so hopefully I'll get it, 6 months, year, 2 years follow up and write this up in a case journal. But this case really just highlights the importance of really just thinking outside the box, being very thorough when you're planning for your surgeries, making sure that you have every single step kind of planned out, and the what ifs, like what if something goes wrong, what are you going to do then? So I'm happy to take any questions now.
Thanks, Dr. Webb. That is a terrifying case to see. Really cool to see someone else present it. I can honestly say I don't know if I would have thought to get the CTA. So that's kind of like what this conference is all about, is being able to learn from each other.